Alright, so we're going to talk about the neurologic system. There's two videos in my PowerPoint that I highly suggest watching. One is the structure of the nervous system, and one is the anatomy of a neuron. These videos, I think, help break it down, possibly better than I do. The nervous system is a glorious and wondrous thing. The brain has the ability to heal itself. In the central nervous system, you have your brain and your spinal cord, and then in your peripheral nervous system, you have your cranial nerves, peripheral nerves, your somatic nervous system, and your autonomic nervous system. The nervous system helps to detect and process sensory information, and it helps to activate bodily responses. So, like I said, in the central nervous system, you have the brain and you have the spinal cord. The brain has gray matter and white matter. The gray matter is neuronal cell bodies, and the white matter is composed of axons and dendrites. Then you have the brain. The top part of the brain is the cerebrum, and it's in two hemispheres, your right and your left hemispheres, and then those hemispheres are divided into lobes. And I have a picture of the brain, and we'll talk a little bit more about the different lobes and what they do. Then in the bottom part of the brain, you have, it's like your primitive brain, basically. And it is your brainstem, your pons, and your medulla. And it's involved in life functions. So you can have injury to your brain, but if it's in the top part, then it's basically your cognition that will be impaired. But if it's in the primitive part, then life functions are going to be impaired. All right, so in your spinal cord, your spinal cord will descend through the foramen magnum. Foramen just means opening of the occipital bone. It goes through C1 and then goes down to the remainder of the vertebral column. The cross section of the spinal cord will show you gray matter, and that gray matter will make up an H. The gray matter, again, is made of neuronal cell bodies, and the H is basically two anterior posterior horns. This gray matter is surrounded by white matter, and the white matter is made up of myelinated axons and dendrites. Then you have ascending and descending tracts in your spinal cord. The ascending tracts, they send sensory data to the brain, and then your descending carries your motor impulses from the brain. You have sensory and motor pathways. The sensory pathways, again, they take your sensory data that's from your body to your brain. So like if you were to experience a burn on your finger, that it's not, your finger doesn't tell you that it's burning, your brain tells you. So these neurons travel along this sensory pathway to tell the brain, hey, I'm having an injury, and the brain tells the body, hey, you need to withdraw that. And this all takes place in a matter of seconds. The motor pathways, the brain to the muscle. So the sensory data of the burn has been sent to the brain, and then the brain is going to tell the muscle to withdraw the stimuli, and that's your motor pathway. Then we have spinal reflexes, and these spinal reflexes don't involve our brain at all. An example of spinal reflexes are deep tendon reflexes, so like the knee-jerk reaction when you stimulate the patella. Some more A and P for you. So we have two types of cells. We have the neuroglia and we have the neuron. The neuroglia is a supporting cell, and it can also regenerate. It's a nerve cell that supports tissue, nourishes, and helps to protect the neuron. And it helps to maintain homeostasis. It's because of the regeneration of the neuroglia that the brain is actually able to regenerate when it has injury to it, which is awesome. Then we have neurons, and neurons are basically our signal transduction. So when, take the example of the burning finger, the neurons are what's traveling up to the brain and traveling down from the brain to say, hey, it's burning. They are a nerve cell. They have the ability to produce action potentials or impulses. These action potentials or impulses, their excitability or irritability, basically. And they transmit these impulses, which is the conductivity. They are composed of a cell body, which is your nucleus, dendrites, which are the short branch-like structures that receive and carry impulses to the cell body, and then axons, which are the long fibers that carry the electrical impulses that are generated by the cell body. And I have a picture of an axon later on. Or, not an axon, I'm sorry, a neuron. So, the neurons, they communicate with each other. One neuron's axon will convey its impulses to the dendrite of the next neuron via a space called the synapse. So it's like a synaptic junction. Basically, the impulse travels down that neuron, travels down that axon, and then it tells the dendrite of the next neuron, hey, this is burning the person's finger, and it just keeps on until it gets to the brain, and then it comes back to the muscle, and the muscle withdraws the stimuli. Then we also have neurotransmitters, and neurotransmitters are chemicals that are released by the axon, which carry the impulse to the receiving dendrite. So they help to assist with communication between the neurons. We have afferent and efferent pathways. Afferent is ascending, so that's how I remember that afferent is ascending. So if you remember one, you should remember the other. They transmit the sensory impulses, and then the efferent, which is descending, transmits motor impulses. So this is the picture of the brain that I was telling you about. The top part is the cerebrum. This is where the higher functioning goes on, and then the bottom part is like your cerebellum. And the cerebellum is your primitive functions. It's for your balance and your coordination. And then you have the brainstem, which also has the pons and the medulla in it, and this is like basically involuntary responses. Then you have your frontal lobe. The frontal lobe is responsible for motor control, problem solving, and speech production. Your temporal lobe on the side is responsible for hearing, language comprehension, and memory and information retrieval. Your parietal lobe is responsible for touch and body orientation and sensory discrimination. And then your occipital lobe is responsible for sight and visual perception and interpretation. So that was the external, and this is the internal. So like I said, in the brainstem, you have the pons and the medulla oblongata. On the inside of the brain, you have the corpus callosum, and the corpus callosum is basically the separation between the right and the left hemisphere. So if you have any damage to the corpus callosum, the person will have an issue getting information from the right side of the brain to the left side of the brain and vice versa. The hypothalamus and the pituitary are also in the brain, and the hypothalamus and pituitary, they play a big role in our endocrine system. The hypothalamus is responsible for temperature regulation, so any issue to the midbrain, which is where the hypothalamus is, the patient will have an issue with regulating their temperature. And the hypothalamus helps to promote and secrete, not secrete, but it helps to tell the pituitary to secrete certain hormones. So any damage to the midbrain, which is where the hypothalamus is, will also cause, it could cause an issue with secretion of certain hormones. This is the cross-section of the spinal cord that I was telling you about. This, remember, is the gray matter, and this H shape, basically. These are your horns. You have the anterior and the posterior side. Then you have these fibers that are connected to the spinal cord, and these are where your neurons are going to come into play. They are your basically ganglion, and the neurons travel along them. So the blue is the afferent. That's where sensory information comes into play. It comes down into the spinal cord. So your afferent transmits your sensory, and then your efferent will transmit to the muscle. And then this is a neuron. And you see it has a lot more than I talked about. But what you really need to know is about the nucleus, because then you have all this other stuff that you learned about in anatomy and physiology about the endoplasmic and the reticulum. That's part of this cell here. But what you really need to be concerned with is your nucleus, which is in the center, your cell body, which is where all this other stuff is included. Then you have your axon, and the axon is how how the sensory impulse is transmitted down, and then it's transmitted into these dendrites. And it tells the dendrites have this little junction here, basically, and it tells the dendrites of the neighboring neuron, hey, there's this burning sensation that's going on. We need to alert the brain, so that the brain can be alerted, and then the brain basically travels down the neurons, like not the brain, but the brain sends a signal down the neurons to tell them to withdraw the stimuli. That's as pretty as simplistic as I can get it. Then we have our peripheral nervous system. And our peripheral nervous system, like I said, is made up of cranial nerves, spinal nerves, and then autonomic somatic nervous system. The cranial nerves are nerve fibers that carry information into and out of your brain stem. This includes information that's related to smell, vision, eyes, muscle, mouth, taste, ears, neck, shoulders, tongue. You have your spinal nerves, which are the peripheral nerves that carry motor commands and sensory information to your spinal cord. And then you have your peripheral autonomic nervous system that includes your somatic and your autonomic. So the somatic is voluntary, and then the autonomic is instinctive. So somatic, you voluntarily control that, and then autonomic is instinctive. So if like you're touching a stimuli that's burning you, then you're instinctively going to pull it away without even thinking. And then the autonomic is parasympathetic and sympathetic, and I'll talk more about that later. So with your cranial nerves, you enter and exit the brain rather than the spinal cord. You have 12 pairs of cranial nerves, and they supply primarily your head and your neck. And they are responsible for the senses of smell, taste, vision, hearing, sensory, and motor function. Then you have your spinal and your peripheral nerves, and they branch from the spinal cord. There's 31 pairs. You have 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. They ascend and descend. You also have dermatomes, which are areas of the body that are innervated by certain nerves. So they can be useful when identifying deficits, because certain deficits are associated with particular nerve lesions. Each spinal nerve has two distinct roots. You have the posterior root, which contains your efferent fibers that receive sensory information from the body, periphery, and convey it to the CNS. And then you have your anterior root, which will contain your efferent fibers. So remember, efferent is coming to, and efferent is going away. So your efferent fibers transfer your motor impulses from your CNS to your muscles of the body, directing and refining movements. What about the autonomic nervous system? So the autonomic nervous system, or ANS, is a control system. It functions below the level of consciousness. So what does that mean? Well, you have like no control over it. It is instinctual. Certain things that the ANS controls. Some examples. These are some examples. They are not all examples. Heart rate. You have no control over how fast or how low your heart goes. Respiratory rate. No control over it. You can control it if you think about it. But generally, we're not thinking about it. The digestive process, we don't control that. Sexual arousal, we can't control that. And in the ANS, we have our sympathetic and our parasympathetic. So your sympathetic requires quick action, so it's your fight or flight. The hormone or the neurotransmitter that's released is norepinephrine. And then we have our parasympathetic, which is not quick, and that's rest and digest. So your sympathetic works quickly, so it burns out quickly. You can't use it all the time. Your parasympathetic is not quick, and it's used a lot more. These two systems will work in tandem to help achieve homeostasis. So how does the nervous system interact with the other body systems? Well, it interacts with every single body system because it has some kind of role to play in everything that is occurring. So with our cardiac, it influences the medulla in the brain. That is how our heart rate is controlled. It is by the medulla. The vagus nerve helps to exert influence over both our heart rate and vessel constriction. And by vessel constriction, then it's going to control blood pressure. And the electrical system of the heart is actually independent of the nervous system. So how does neurovascular or neurologic system and the respiratory system play? Well, again, the medulla regulates inspiration and expiration. Your pons regulates your respiratory drive, and your vagus nerve relays data on arterial blood gases to your medulla. We can voluntarily control our respiratory rate, and this is achieved via motor neurons, but it's not something that we can do 100% of the time. We can only voluntarily control it when we're thinking about it, and you can't think about the respiratory system all the time, or you would not be able to think about anything else. How does the neurologic system and endocrine play a role? Well, like I was talking about in the picture of the brain, the hypothalamus stimulates the pituitary to release certain hormones. These hormones are the antidiuretic and oxytocin hormones. So antidiuretic hormone plays a role in regulation of the volume within our body, and then oxytocin plays a role in basically pregnancy and bonding. The endocrine secretes certain glands that are regulated by nerves, and then it also regulates the parathyroid hormone. This parathyroid hormone affects electrolytes and metabolism, and that can affect neurologic function. And then musculoskeletal. Well, the muscles are innervated by the neurosystem, and then they receive impulses from the cerebral cortex to carry out both voluntary and reflexive movements. Pretty sure I've talked about that a lot. So what are some developmental, cultural, and ethnic variations? In our newborns and in infants, there's a lot of screening done. A lot of screening done during pregnancy and within the first 24 hours of life to determine if there are any neurological variations. Spina bifida is one of those neurological variations. Remember, spina bifida is a neural tube defect that occurs where the spine basically, there's a hole in the lower part of the body, and the spine is exposed, and it can be pretty traumatic for both parent and child. Be a lot of like child can be paralyzed. There can be a lot of issues. And when a newborn is first born, they assess for a lot of primitive reflexes that will disappear later in life. And the reason that they're doing this is because if they have an issue with these primitive, like if they don't have these primitive reflexes, then more neurological screening will need to occur. With children and adolescents, generally your neurologic pathologies are caught in infancy, but some might not present until later in life when personality is taking over, is the best way to say it. Some of these things like obsessive compulsive disorder or ADHD, attention deficit with hyperactivity, these are things that are not going to be noticed until the child has developed more and you notice those pathologies. Children can also have febrile seizures. This occurs when your hypothalamus is immature, and in a child's brain, the hypothalamus is immature till about 5 years old. The hypothalamus, like I said earlier, it regulates temperature. So what happens with febrile seizures is that they get like 100.6 temperature, and they can't regulate that temperature, and it just goes crazy high, and that's what causes the febrile seizure. In pregnancy, like I said earlier, neural tube defects can occur, which is why folic acid is suggested for women who are of childbearing age. A pregnant woman can develop certain neurologic pain, such as carpal tunnel, numbness and tingling in their thighs, and they can also develop hyperactive reflexes because their magnesium level drops, and this can result in preeclampsia, which also can lead to seizures. And then in the older adult, they tend to lose neurons and their impulses slow. Their reflexes diminish, their sensation decreases, their taste decreases, and I have more on the older adult on the next slide, but please remember that loss of intelligence, loss of memory, and loss of judgment are not normal parts of aging, and they need to be assessed. The older adult also tends to, their muscle mass decreases, they may start to develop mild tremors, their gait is a little bit slower and it needs to be more deliberate so they don't fall. Their gait can deviate. They may have difficulty with rapid alternating movements. If once a person is greater than 65, their vibration sensation at the ankle, the loss of that is common. They may need stronger stimuli for touch or pain, and their plantar reflex can be absent. With cultural things, you want to ensure that your questions are not culturally specific. One of the big ones here is who's the president of the United States, who's the first president, can you tell me the last 4 presidents? So if you have someone of a different culture, they may not be able to answer those questions, and it's not necessarily because something neurologic is going on, it's just because they don't know. Certain cultures and ethnicities will have a higher incidence of certain neurologic diseases. An example, African Americans have a higher incidence of hypertension. And this hypertension, if it's uncontrolled, can lead to stroke. The Irish population has a higher incidence of neural tube defects and phenylketonuria, or PKU. Your Navajo Native Americans, they have a unique neuropathy, and this causes an absence of myelinated fiber, which causes weakness, hypotonia, areflexia. They have sensory loss in their extremities, corneal ulcers, and painless fractures. Generally causes death by age 24. I imagine nobody here has seen that because we don't have a very high Navajo population. So relevant medical history. What are some questions we need to ask? If they've been experiencing any numbness, any tingling. If they have been experiencing numbness or tingling, is it localized on one side or the other? What part of the body are they having it? Is it in upper extremities, lower extremities? If they're having any visual issues, any headaches, what kind of pattern to their headache? We need to assess their pain, do old cart, how long have they had the headache, where is it located in the head, is it a specific place or is it all over, the duration of the headache, characteristic, anything aggravate it or relieve it, and anything the patient has done for the headache before seeing us. Are they experiencing any dizziness, any speech issues, any swallowing issues, any fainting, any loss of muscle function, any memory loss, any behavior changes? All of these questions will lead us down the road of, is it a stroke? Is it a transient ischemic attack? Is it multiple sclerosis? And then much more. Our risk factors in our family history. Do they drink any alcohol? If so, how much? Are they smoking? And not just smoking cigarettes, but chewing tobacco. Are they using any recreational substances? Is there any family history of neurological problems? Is there any family history of migraines? Things to do to promote their health, to help prevent stroke and transient ischemic attacks. Some strokes are just unpreventable. There's nothing that you can do about them. But majority of strokes have modifiable risk factors that we can address, such as promoting smoking cessation, healthy eating, exercise. We can help address disease-specific risk factors such as atrial fibrillation, coronary artery disease, or sleep apnea. And then we want to educate them on the symptoms to recognize the FAST acronym. So, and what does the FAST acronym stand for? So, facial drooping, arm weakness, speech difficulty, and if you have all these things, it's time to call 911. And outside of the FAST acronym, are they having any sudden numbness or weakness of the leg, arm, or face? Any sudden confusion or trouble understanding? Any trouble seeing in one or both eyes? Any trouble walking, dizziness, loss of balance or coordination? Or a sudden severe headache with no known cause? These are all problems that should be concerning. The carotid artery screening. So if the patient is symptomatic, they should be screened, and the screening is it's a duplex ultrasound. However, if the patient is asymptomatic, then they should not be screened, according to the U.S. Preventative Service Task Force. We want to help reduce the risk of peripheral neuropathy, and one way we can do this is to help promote optimal glucose control. Sugar is toxic to the body and causes so many issues. The herpes zoster vaccination, we want to help promote patients getting that, especially our older population. It's recommended for adults that are greater than 60, but post-traumatic neuralgia, which is caused by having been exposed to the herpes zoster virus as a child or as a young adult, can occur in anybody 50 or older. And actually I've seen it even younger, but the majority of patients usually get it after the age of 50. And then to detect the 3Ds. What are the 3Ds? Delirium, dementia, depression. How can we help detect it? So we can use the confusion assessment method, which is there any acute change in their mental status and fluctuating course? Is there inattention? Do they have difficulty focusing? Are they having disorganized thoughts? So are they having rambling or irrelevant conversations? Is it illogical? Or the abnormal level of consciousness? Are they anything besides being alert? Are they hyper alert? Are they lethargic? Are they stuporous? These things can be indicative of delirium. Depression can be common with those that have a lot of medical issues. So it needs to be screened for, especially if there's significant medical conditions going on. And then dementia should be assessed for by the mini mental status examination. So we want to look for objective data. We're going to look at their mental state. So we ask our orientation questions. Can you tell me your name, your date of birth, where you are, what month, what year, what brought you to see us? We also want to assess for abstract thinking. If there's abstract thinking will show us if there's connections between two objects. Then we assess for attention. One popular way is doing serial 7. So you have them count backwards from 100 by 7. If patients have difficulty, they could suffer from dementia, depression, or maybe they have some kind of intellectual disability. We want to assess for comprehension. This is the ability to read and follow directions. Assess for general knowledge, so ask basic facts. And remember that people from other countries might have a hard time with this if the general knowledge is related to United States. You want to assess their judgment. If they have poor judgment, it could be a sign of delirium, dementia, intellectual disability, psychotic states. You want to assess their memory. If they have issues with memory, it could indicate some underlying disorder, and you want to assess their vocabulary and their articulation. Articulation being like slurring, stuttering, hesitation. So cranial nerves, you have 12 cranial nerves that I will talk about in more depth. Those need to be assessed. Our motor system should be assessed. Symmetry, size, strength, tone, balance, gait are in the sensory system. You want to look at what they can do with their eyes closed, if they have issues with trying to keep their balance with their eyes closed, their perception of touch, vibration, position, and then you're going to also assess their deep tendon reflexes. Now, deep tendon reflexes are probably only going to be assessed in a neurological setting or in labor and delivery, because women that are pregnant, they can have hyper-reflexive DTRs, which is a sign of their magnesium level being low, and that can lead to seizure. Oh, I talked about all this already. So your cranial nerves. We have the olfactory nerve, which is basically smell. They only test it for, if there is a loss of smell, head trauma, abnormal mentation, or intracranial lesion. The way you test for it is closing your eyes, occluding one nostril, presenting smell on alternating sides. Then your optic nerve, you're going to test your visual acuity. Use the Snellen chart for that, and then you also test their peripheral vision. For 3, 4, and 6, the oculomotor, trochlea, and abducens nerves. That tests perla, cardinal fields of gaze, and palpable fissures, which is the top of the eyelid and the bottom of the eyelid. It's the opening. The trigeminal nerve, motor, sensory, and corneal reflex. You palpate the temporal and masseter muscles as your teeth are clenched, and then you try to separate your jaws by pushing the chin. The sensory is light touch to face, and then with the corneal is done without contact lenses. Touch eye with wisp of the cotton ball, and they should blink. So if somebody, I'd only see the corneal reflex being tested if somebody's like intubated, or if they are really obtunded and they are not like blinking, because if somebody's alert, they have a positive corneal reflex. But I do test the corneal reflex on my intubated patients to make sure that they have it. Facial nerves, so going to see if they can smile, frown, lift their brows, show their teeth, and then the sensory part of it, if they can taste certain things like sugar or salt. The acoustic nerve, you would use the whisper test. The glossopharyngeal and the vagus, you're going to depress their tongue with a blade, and you want to note if their uvula and their soft palate rise. You know, my friend Katie doesn't have her uvula, so you can't really test that on her. You want to touch the posterior pharyngeal wall with the blade to see if they have a gag reflex. And I would hope, again, that if somebody is alert, they would have a gag reflex. I don't know that I would want you to do that on somebody that is alert. But if you have a patient that is complaining of not being able to swallow, or if you have a patient that is intubated, you couldn't really check a gag reflex because they have a tube down their throat. I mean, I guess you could if you really tried. But I digress. If somebody is alert and you stick a tongue depressor down their mouth, they're probably not going to be happy with you. The spinal accessory nerve, and so the way you test that is to rotate their head against their chin to see if they have resistance, shrug shoulders against resistance. The hypoglossal nerve, you want to do the tongue thrust, say light, tight, dynamite, to see if they are distinct with how they say those letters L, T, D, and end. For the muscle part of it, you're going to compare sides. So you compare your upper and your lower extremities and the right and left. You're going to look at your strength, your extremities, your neck, and your trunk, and look at your tone. I think that's a misspelling. That should be perform range of motion in each extremity, not an F there. I don't know why that's there. So they should have normal tension and relaxed muscles. You're going to look at their balance and their gait to test their cerebellar function. Have them walk 10 to 20 feet and then come back. And you want to have them walk normal to note arm swing, rhythmic walking, normal stride, and then you're going to have them walk heel to toe and then walk on their toes and their heels. Again, this will let us know what their cerebellar function is. So if there's an issue with their cerebellum, you'll see it with walking. Then have them do a shallow knee bend or hop in place on one leg, then alternate. Then with the Romberg test, you're going to have them stand with their feet together, arms by side, and their eyes closed. And if they sway, then that is positive. You don't want them to do that. Coordination and skill. So rapid alternating movements, pat knees with both hands, flip, and then pat with the back of the hands, and have them do it faster and faster. And again, your older population might have a hard time doing this. Finger to nose, and then supine position, heel to ankle on opposite leg. To note their sensory, you're going to have their eyes closed, and you're going to put various stimuli on distal locations to make sure that they can identify it. So pinprick, cotton ball, something wet, and have them have their eyes closed so they can't cheat. Because you want to be able to see if they can feel these things. And you're going to compare symmetrically. So you're going to do right and left in the same place. You want to compare pain. So you can do the like pen to finger test, where you squeeze their finger with a pen. But again, I would not do that on somebody that is alert because they are going to smack you. But if you have them close their eyes and you touch them with a painful stimulus, such as like the sharp tip of a needle, that would be okay. Just do it lightly so that you don't cause any issue. See what if they're having any issues with temperature, and light touch. You're going to have vibrations over bony prominences, kinesthesia, which is the perception of position. Stereognosis is a description of an object, so you have them close their eyes and you put something in their hand. If somebody has astereognosis, it indicates Alzheimer's or lesions of the sensory cortex. Graphesthesia is you trace like an 8 on their hand. Their eyes are closed and they say what you traced. Do 2-point discrimination, which is 2 separate simultaneous pinpoints on the skin. Extinction, which is something that's done in the NIH scale. A lot of this is done in the NIH scale, which is the stroke scale. But you simultaneously touch both sides of the body at the same point. And they, if they feel it on both sides, then that's good. And if they don't feel it on both sides, then they aren't noticing that one side is there. And then point location is touching the skin at a certain point. So the DTRs, again, DTRs is something that would only be done in a neurological setting, or if you have a patient who is having some electrolyte abnormalities such as magnesium, or in a labor delivery setting. So a deep tendon reflex, it's a subjective skill and it requires clinical practice. So if you don't practice them on a regular basis, you're not going to do them well. It's not always 100% reliable, and you're going to relax with your muscles partially stretched and stimulate with short, snappy blow of hammer, and you want a reflex hammer, not like a real hammer, at the tendon of the muscle insertion when you're going to compare your left and your right. And this is your scale. 0 is no response. 1 is diminished or below normal. 2 is average. 3 is brisker, and 4 is very brisk. And then there's 5, which isn't on this scale, and that's like clonus. And clonus is basically like a continuous muscle spasm. So if you initiate the DTR and you get like a continuous muscle spasm, that is really not good. So these last couple of slides just talk about where to do deep tendon reflexes, so I'm just going to let you read them over because this is already way too long. And then plantar reflexes. Again, this is like something that you're going to have in a baby, the Babinski. And what a positive Babinski is when you go rub up the foot and your toes fan out. You generally are not going to have that in the adult population. Alright, and these are my oodles and oodles of references. So, I hope you have enjoyed this 45-minute video. And I apologize for how long it is, but the neuro system is very, very detailed and complex. If you have any questions, please let me know, and I will see you on the flip side.